to our January Teach Educational Rounds. Here with us today, we have Dr. Sachin Pasricha, who will be presenting on the effect of smoking on renal health and tailoring cessation strategies to patients with renal disease. So we're going to begin with KMH's land acknowledgement. KMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of KMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. KMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis and share the land and protect it for future generations. Now I invite everyone to introduce yourselves in the chat and let us know which traditional territory you are joining us from today. If you're not sure, I can put a link in the chat where you can find out. And you're also very welcome to let us know something that you're doing to learn or improve your commitment to reconciliation. And while I'll give everyone a moment to do that, I'll also share a bit about myself for those that are joining for the first time. So my name is Natalie, and like KMH, I am currently located on the lands of the Mississaugas of the Credit. I'm a third generation Canadian. My grandparents came from Italy. And last year I moved to Toronto, where I have grown to truly appreciate the community and vibrancy that this land has to offer. I acknowledge the privilege I have as a white settler to live here, especially as someone living with type 1 diabetes. I'm particularly grateful to have access to insulin and all my other required medical supplies. So I myself am committed to reconciliation. I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard and reflected within my work and personal life. So I'll give everyone a few more seconds to share, and if not, I'll keep going with some housekeeping items, but please do continue to share in the chat. We do read all your comments. So if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you have registered for the webinar and completed the pre-assessment. As well, make sure you have signed into the webinar using your full first name and last name so we can track participation. And last but not least, please make sure to complete the evaluation and post-learning assessment that will be emailed to you by the end of the day. Along with that, you will also receive a copy of the slides as well as this recording if you would like to review or share with any colleague. So here's a little bit more information on our presenter today. Dr. Sachin Pasricha is a third-year resident medical doctor in the internal medicine program at U of T. He completed his medical school at Queen's University and then decided to pursue internal medicine in Toronto and will be beginning nephrology training in July. So he's interested in how the nephrology community can collaborate with smoking cessation experts and has actually completed the TEACH certificate program himself. So welcome, Dr. Pasricha. And so no disclosures to report on his end. Please note that the content of Teach Educational Rounds is centered on evidence-based guidelines from the following sources. Nonetheless, these materials are general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So please feel welcome to use the chat feature throughout the webinar to post any comments or answer any prompts from the presenter. To do this, you can click on the speech bubble icon in the control panel at the bottom. And please ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. Although we will ask that you hold all content-related questions to the end, as we'll have a Q&A period at that point. So keep note of anything that comes up and put it in the chat at that time. So with that, I will leave it to our presenter to take it away. Thank you, everyone, and enjoy the webinar.
Thank you so much, Natalie. As mentioned, my name is Sachin Pasricha. I'm one of the internal medicine residents in Toronto. And it's an honor to be here, and thank you for having me on the Teach Educational Round series to present to you. Before I go any further, I'd like to share my own brief land acknowledgement statement. Like Natalie, I am at KMH, located on the lands of the Mississaugas of the Credit, covered by Toronto Purchase Treaty 13. I'm also a third generation Canadian, with my grandparents coming here from India in 1968. It has been an absolute privilege to be raised in Canada and live on these lands. I am committed to reconciliation, and I do this by eagerly asking clients from Indigenous communities about their voice, cultural practices, and how we as a healthcare community can best serve them. Today, my presentation is going to focus on the effects of tobacco on renal health and how to tailor smoking cessation strategies to patients with renal disease. I'm here at KMH doing an elective with the Nicotine Dependence Clinic with Dr. Selby and the rest of the team here, and I'd like to thank them for their training and the opportunity to speak here. Before I go any further, if I have any technical difficulties and you can't hear me or the slides are not going forward, please, Natalie or anyone else, don't hesitate to just interrupt me and speak up. As well, if you have questions during my presentation, I have the chat open. Feel free to message them and I'll do my best to answer them as I go on. Otherwise, we can do them at the end. And there are a few questions I have for you, so feel free to use the chat to answer those as well. So I have 3 learning objectives for all of you today. The first is I hope that after this presentation, you can describe how cigarette smoking actually affects renal health, both in people from the general population and then people with pre-existing renal diseases, kidney diseases. The second is to appreciate how smoking cessation can positively impact long-term renal health in both these populations, the general population and people with pre-existing renal disease. And the final, probably one of the most important, is that whenever someone sees a client or patient with renal disease, any type of clinician always asks the question, they see a high creatinine value or someone with kidney disease, can I prescribe this medication in this patient who has renal disease or who's on dialysis? And everyone gets a little bit nervous, probably rightly so. So my third objective today is to provide you insight into how to use our pharmacologic tobacco cessation strategy safely in patients with renal disease and or who are on dialysis. So to start off, the first part of this presentation is about kidney health. Why do we care about kidney health? To be brief, the kidneys, one of their main functions is to excrete toxins from the body. And in some people, for a variety of reasons, the kidneys fail. If the kidneys fail and we can't excrete toxins, that would lead to death. But in some patients or clients who are a candidate, we can pursue other options such as dialysis or a kidney transplant, both of which would replace the function of the kidneys. It seems great, but the issue is both dialysis and or a kidney transplant come with increased risk of death, decreased quality of life, increased cost to our healthcare system, and increased hospitalization. So, blanket statement, the best thing for kidney disease in general is to prevent it from occurring in the first place. That's why I'm going to talk to you about tobacco and its effects on renal health. The real question being, does it impact renal health? As alluded to, I'm going to focus on 2 distinct populations here. The first, these images are fictional and they're not real cases, but the first is exemplified here. A 42-year-old man, supposedly healthy gentleman who smokes half a pack per day. And the second broad strokes population is an 83-year-old female who has diabetes and already has diabetic nephropathy, a condition where the diabetes has impacted the kidney and caused kidney damage, and has other risk factors for kidney disease such as high blood pressure. But she also smokes half a pack of cigarettes per day. The question is, how does this half a pack of cigarettes per day affect the renal health in the general population and in patients with pre-existing renal disease? I'd actually like to start with people who have pre-existing renal disease, because when you look at the literature, i.e. the research, a lot of the earlier, i.e. more historical data on the impacts of tobacco and renal health actually come from people with pre-existing kidney disease. So pre-existing kidney disease comes in a variety of forms, but I've summarized it into 4 main groups. Those being diabetes and high blood pressure, 2 of the leading causes of kidney disease. Those with primary renal disease. So these are conditions conditions like lupus, other inflammatory or rheumatologic conditions, some genetic conditions that are all associated with kidney disease. And then finally, patients with a kidney transplant. So in each of these groups, how does smoking tobacco affect kidney health? Let's start off with people with diabetes. This was looked at as early as 1994 in this study of patients with type 1 diabetes, about 100 patients who had type 1 diabetes and already had that condition I mentioned called diabetic nephropathy, where diabetes has impacted or caused some disease in the kidney. And essentially, what the study looked at is over time in these 100 or almost 100 patients, how many of the patients developed worsening kidney disease? And they split it up. So current smokers, 53% of them had worsening kidney disease, whereas in non-smokers, that number was 11%. And there was a statistically significant difference there. So you might say this is a small study. Well, it's been replicated many times, these results, and essentially more recently, as of 4 years ago now, 2023 we're in, there was a meta-analysis done on smoking and diabetic nephropathy or kidney disease from diabetes. And the overall summary is that smoking is a risk factor for the development of diabetes-related kidney disease and also accelerates the progression of it. So what can we say about diabetes? First thing is that tobacco smoking is associated with acceleration of diabetic kidney disease in those who have it. And for people with diabetes who don't yet have it, it creates a higher likelihood that they will actually develop kidney disease from diabetes. What about our second group, patients with high blood pressure? So this is a study that essentially looked at patients with high blood pressure and said if they smoke or not, let's test their urine to see if they are spilling protein. Why? Because people who spill protein in the urine are more likely to develop kidney disease. It's sort of a marker of kidney disease. And essentially, in people who had high blood pressure, those who smoked were more likely to have protein, which we call albuminuria, protein leaking in the urine. And another study found similar findings. This one looked at patients with high blood pressure to understand what risk factors lead them to develop chronic kidney disease, CKD, and smoking status was again a risk factor. So we see with people with high blood pressure, smoking is associated with protein leaking in the urine and the development of chronic kidney disease. Now, what about those patients with what I described to you as primary renal disease? There's a lot of conditions in this group, so it's hard to summarize them, and they're certainly not a homogeneous population. But one study grouped a couple of these groups of patients together. These are patients with a condition called IgA nephropathy and then a genetic condition called autosomal dominant polycystic kidney disease. Essentially, what the study looked at is how likely were people to develop kidney failure, another name for which is ESRD, end-stage renal disease, and it was more likely in people who smoked if they weren't on a medication we call an ACE inhibitor. And as mentioned, this is not a homogeneous population, but another post-hoc study tried to look at patients with a variety of forms of primary renal disease and essentially looked at year over year how fast did their kidney function decline. In non-smokers, it declined at 2.5 milliliters per minute per year. And that milliliters per minute per year is just the units we used. But in moderate smokers, the kidney function declined faster at 3.6. And in heavy smokers, being those who smoked greater than 25 cigarettes per day, it declined at 5.3 per year. So what can we say about patients with these primary renal diseases? The general sense is that, again, smoking is associated with progression of these diseases. And what about kidney transplant? We invest a lot in transplants across the board, and kidney transplants are the most common type of transplant. And often a transplant lasts around 15 years, but there are a variety of factors that can impact that. And the goal with the transplant is to get it to the transplanted organ, so in this case, the kidney, to survive as long as possible. And anything we can do to help that is helpful. So what you'll see here in this study is that graft refers to the kidney transplant. The kidney graft survival at 1 year, it's a little bit misaligned, sorry about that. At 1 year, non-smokers had a graft survival of 88%, and smokers had a survival of 84%. And if you fast forward all the way to at 10 years, non-smokers had a graft survival of 62% compared to 48% in smokers, and that p equals 0.02 at the bottom shows that this is significant. So what we can see is that people who smoked at the time of their transplant were actually more likely to lose their transplant earlier. That's a big deal considering the impact of this how our goal in transplant is to get it to survive as long as possible. So what's our general summary? Well, people who have pre-existing kidney disease, smoking accelerates the progression and the development of that kidney disease in a variety of forms. Protein in the urine, declining kidney function, actual failure of kidney transplants. So smoking is detrimental to the renal health of these clients. So now we've talked about when someone like this, who has diabetes and already has kidney disease related to their diabetes, comes to you and asks, does smoking actually further damage my kidneys? Now you have an answer and can reliably say with evidence the answer is yes. But what about the majority of people, probably a lot of many people on this call see, who are part of the general population and don't have kidney disease to begin with? Question is, does tobacco affect their renal health? And to do this, there's actually been a variety of studies from various nations worldwide. So that's why I'll sort of display those studies to you on a map. The first is in 2003 from Maryland, USA, and essentially looked at 23,000 people and found that current cigarette smoking came with an increased risk of CKD, chronic kidney disease. The question a lot of people are going to ask is, how much does smoking actually increase my risk of kidney disease? So you'll see for smoking, the hazard ratio, HR, was 2.6. And then for a systolic blood pressure, SBP, of 140 to 159, the hazard ratio is 3.2. So roughly similar. So the answer is that cigarette smoking increases the risk of chronic kidney disease about the same amount as that moderately high blood pressure. As you can see, high blood pressures, significantly high, of over 180, or diabetes, have higher hazard ratios, implying that current cigarette smoking increases someone's risk of chronic kidney disease about the same as moderate blood pressure, but not the same as severely high blood pressure or diabetes. Well, was this reproduced in any other studies? An Italian study did reproduce it in 2005, and this study more focused on the older population, 65 to 84, and again found that current smokers of greater than 20 cigarettes per day had an increased risk of kidney function declining. The question becomes, if smoking increases your risk of chronic kidney disease, is it just increasing the risk of more mild kidney disease, those being stages 1 and stages 2, or is it actually causing more moderate forms of kidney disease, such as chronic kidney disease stage 3 or kidney failure, like I mentioned, known as ESRD, end-stage renal disease? There's a Japanese study of over 100,000 people that gave us insight onto this. And essentially, they found that current smoking predicted early chronic kidney disease, stages 1 and 2, with a significant extent in males and females, with the hazard ratios being 1.26 and 1.4, and both of the confidence intervals were above 1. But also, current smoking predicted chronic kidney disease stage 3 plus in males and females, and you'll see the significant hazard ratios there. So what we know is that current smoking predicts both early and later stages of kidney disease. Not only that, but another European study focused on smokers versus non-smokers and looked at almost 200,000 people. And this was quite a lengthy study. It followed people from 1988 all the way to 2005 and found that smoking increases the actual risk of kidney failure or end-stage renal disease, so the last stage of kidney disease. All these studies so far were voluntary, but the biggest study actually comes from Korea, which was a nationwide survey of over 23 million people, and reaffirmed a lot of the findings I've already displayed to you, finding that current smokers had an increased risk of end-stage renal disease by 39%. And you'll see there, based on that confidence interval, that that's significant. So now I'm going to hand it over to you. When someone from the general population comes to you and says, and maybe they've read somewhere that smoking does or does not increase my chance of chronic kidney disease or end-stage renal disease, what can you tell them? Maybe put it as a yes or no in the chat. Does smoking increase their risk of chronic kidney disease or end-stage renal disease? Great. I'm glad to hear that we're moving along the right page. The answer is yes, and I think it sure does is correct. Also, thank you all for all the participation. Um, and it's actually true for both early kidney disease, late kidney disease, and altogether kidney failure, end stage renal disease. And then because people are going to ask how much, I gave you some insight into this, but how would you answer that question? How much does smoking increase my risk of kidney disease? Yeah, I think that's probably one of the best way to put it. As much as to as much as mild to moderate high blood pressure. So essentially similar to a blood pressure of 140 to 159. Um, but it's not as much as conditions such as diabetes or severely high blood pressure, but it still is significant and it's potentially reversible too. But we'll get into that. And a lot of people want to know, is this evidence based? And the answer is yes. It's from large trials from several nations. I actually mostly showed you studies from developed nations, but there's a few other studies from developing nations as well. Someone has a question, moderate, but should we also consider that smoking increases high blood pressure? And I appreciate you bringing that up. A lot of the studies that I displayed to you adjusted for the fact that smoking, as Rosa mentioned, does cause high blood pressure, and high blood pressure in itself causes kidney disease. So these were adjusted studies. So they looked at how much does smoking, independent of its effect on blood pressure, cause kidney disease or contribute to the acceleration of it. And but high blood pressure is yet another mechanism through which kidney disease can cause high blood pressure, and that wouldn't be accounted for in a lot of the numbers I gave you because those were adjusted numbers. But to move on, the next question someone from the general population would logically ask you is, does reducing how much I smoke help from a pack to half a pack or half a pack to a quarter? And does smoking cessation altogether help? To answer this, we'll go back to our map. The first insight comes from a US study that looked at the relative risk of chronic kidney disease. And essentially, when you compare those who smoked less than 20 cigarettes per day versus non-smokers, there was no they didn't achieve a statistically significant difference. That doesn't mean that there's no impact on chronic kidney disease, but they didn't achieve it. And for those who smoked greater than 20 cigarettes per day versus non-smokers, they did, implying that reducing how much you smoke probably does have a positive impact on renal health. And then a Norwegian study actually was quite big, of 65,000 people, and looked at risk factors for end stage renal disease and found similar findings. Essentially, if you look at people who had 1 to 9 pack year history of smoking, their hazard ratio is 4.21. And that is sort of a quantification of their increased risk of end stage renal disease due to that 1 to 9 pack years. But if you go all the way down to those who had a greater than or equal to 40 pack year history of smoking, their hazard ratio of 37.7. And the numbers keep going up. And you see this test of trend in the bottom right hand corner is significant, implying that the more pack years of history of smoking comes with increased risk of end stage renal disease. So the answer to does reducing how much I smoke help is yes. The second question is, does smoking cessation altogether help? Probably yes, if reducing how much you smoke helps, but this is also looked at in a separate way. That same study looked at current versus non-smokers and then former smokers versus non-smokers, and the hazard ratios are just smaller because the populations here were bigger. But essentially, current versus non-smokers had a hazard ratio of 4.01, and it was less, 3.32, for former versus non-smokers, suggesting that former smokers were at less risk of end-stage renal disease than current smokers, implying that cessation does help. And then that Japanese study I mentioned before found similar findings, whereas when you look at current versus non-smokers and their chance of early kidney disease, the numbers are significant with hazard ratios and confidence intervals above 1. Whereas when you look at former versus non-smokers, the hazard ratios are closer to 1 and the confidence intervals cross 1, implying that former smokers are not as at risk for the development of early kidney disease as current smokers. And finally, that Korean study found similar findings, a very, very large study, finding that current versus non-smokers had a 39% chance more risk of end-stage renal disease, whereas when you looked at former smokers, the risk was 9% more. So the answer is smoking cessation does help. And I'll add one more attribute to this statement that smoking cessation does help. And that came from the Norwegian study that essentially looked at, okay, you've quit smoking for 1 to 4 years, so you've been abstinent for 1 to 4 years versus greater than or equal to 20 years. Do these extra years of abstinence actually help? The numbers are not as convincing when you look at those individual hazard ratios, but when you look in the bottom right-hand corner and they test for trend, they actually do find significance, implying that longer time of smoking cessation or longer time of abstinence brings added benefit to the kidneys or added renal benefit. So the summary for the general population is that smoking increases the risk of early, late, and end-stage renal disease about the same amount of a high blood pressure, with the caveat that that's as mild to moderate high blood pressure, with the caveat that there are other mechanisms that were adjusted for that probably increases the risk of smoking, such as the fact that it contributes to high blood pressure, and that reducing smoking or smoking cessation does help. What about people with pre-existing kidney disease? I'll just go to that last question. Does smoking cessation help them? And this was the first study I showed you, and this study actually supports the idea that smoking cessation does help, because they found that current smokers, 53% of them had worse kidney disease, former smokers, 33% of them had worse kidney disease, and non-smokers, 11% of them had worse chronic kidney disease, implying that former smokers did better than current smokers, and that difference was significant. So what we know is that even in people with pre-existing renal disease, smoking cessation does help their kidneys. So far, we've gone over the effects of tobacco on renal health in the general population and patients with renal disease, and I've told you that smoking cessation or reducing does help renal health. But the question is, and this was sort of alluded to by Rosa, who asked the question, how does smoking cause high blood pressure? Well, one of the things that was mentioned is that smoking causes high blood pressure, which causes the progression of kidney disease, but there's a variety of other mechanisms. It causes oxidative stress on the body, decreased oxygen, an inflammatory response, and there's other ones such as spilling protein that is not even mentioned here. All this is to say, probably the reason a lot of those studies were positive was because there's so many ways that smoking does damage the kidneys from a basic science perspective, but I won't go into the basic science here. So if we know smoking cessation or reducing how much one smokes helps both in the general population and patients with kidney disease, the question is, how do we achieve that? How do we help people achieve smoking cessation to help their kidneys? Well, these probably a lot of you have heard of. These are our first-line agents when it comes to smoking cessation pharmacotherapy: nicotine replacement therapy, bupropion, and varenicline. The question is, how do you apply those to people in the general population and people with pre-existing kidney disease? A lot of you have probably attended numerous of the Teach educational round seminars, so you're probably familiar with how to apply these agents to the general population. So I really symbolize that with a check mark because patients from the general population were saying that they don't have kidney disease to begin with, you can apply those agents as you already know how to apply them. And just the only extra piece of information I've given you is that it's helpful for their kidney health also, smoking cessation. But where I'm going to focus the remainder of the talk is on this question mark. In patients with kidney disease, can we use these pharmacological strategies? And to answer that question, the first thing we have to know a little bit about is how do we actually classify someone's degree of kidney disease? So I alluded to this before, but kidney disease comes in a variety of stages. Chronic kidney disease stage 1, 2, 3, 4. And then stage 5 is often also referred to as ESRD or end-stage renal disease. And some people in that category have to have their kidney function replaced with usually dialysis or a transplant, and the two types of dialysis are called hemodialysis, which is through an IV, or peritoneal dialysis, which is essentially through the abdomen or the peritoneum. And how do we figure out which bucket an individual client or patient falls into of chronic kidney disease? Well, we look at a value called their creatinine clearance or estimated glomerular filtration rate. And essentially that value tells us how much, almost in terms of a percentage, but not exactly, how much of their kidneys are actually functioning compared to normal, healthy functioning kidneys. And so a number of greater than 90 would equate to chronic kidney disease stage 1, 60 to 92, 30 to 63, etc. And then less than 15 is end-stage renal disease. But how do you know which of these buckets someone falls into? Well, most of our electronic medical records kindly calculate this glomerular filtration rate for us, so it'll actually be a number on the electronic medical record. But if for some reason it doesn't, the electronic medical record will give you a creatinine or CR value for a patient, and you can usually use that to figure out what bucket someone falls into. Essentially, you Google MD Calc GFR equation, and then you plug in a few values such as an individual's sex, age, and then their creatinine or CR value, which I put 130 here as an example, their race, and the calculator will then tell you what their glomerular filtration rate is. So for this person, it was 34.2. And that will help you figure out which of these buckets that individual falls into. And that's important for figuring out how do we adjust our pharmacological smoking cessation strategies. Now, why have I put these dotted lines here? Well, essentially, I put these dotted lines here because, as you'll see in the coming slides, patients with CKD stage 1 and 2 have mild kidney disease, 3 has moderate disease, 4 and end-stage renal disease has severe, and then there's the dialysis population. And these lines are essentially where adjustments in our pharmacological agents are needed in terms of dosing. So let's start off with our first agent, which is nicotine replacement therapy. And can we use that in patients with kidney disease? When we're looking at giving any medication to someone with kidney disease, really what we ought to understand is, okay, that medication goes into the body. How much of it is actually excreted by the kidney? So nicotine in healthy individuals, 5% of it is excreted by the kidneys. In those with mild kidney disease, it's 3%, moderate, it's 2%, and severe kidney disease, it's 1%. So it is less in patients with severe kidney disease, but the bottom line is these are numbers like 5% and 1%. So essentially, not a lot of the nicotine is actually excreted by the kidneys. That would imply that if someone is starting to develop kidney disease, because the kidneys are not responsible for a large amount of nicotine excretion, the question is, do we really need to adjust the doses of the nicotine replacement therapy in these people? And that's the question I'll lead to the audience, and I'll maybe get everyone to answer in the chat. Do you think, in light of what I've told you, that we need to adjust the dose in clients with renal disease? Great. And I think everyone's sort of along the same lines. Based on what I've told you, the answer would be B, no change. And I appreciate what Marilyn has written there. This is what I'm talking to you about is just in relation to the respect of the kidneys. There are other factors in other clients, such as elderly age, that might make us more, and a lot of patients with kidney disease, truthfully, are of the older population. So due to the kidneys alone, we don't need to adjust things. So the answer would be B, but there are other factors in these clients, for example, older age, that we might need to adjust their nicotine replacement dose for. So this is from the Nicotine Dependence Clinic here, and essentially all I'm telling you here is that the official recommendation is to, there's no recommended difference in dose for patients with chronic kidney disease or dialysis. Now I will caution you and say that the kidneys work differently in every individual, so even though you might not start off at different doses, or you might not use a different dose when you're adjusting the dose of the nicotine replacement therapy in these people, we should still be aware that they have chronic kidney disease. And if someone is coming to you with symptoms suggestive of nicotine toxicity, you should be aware of the fact that the kidneys might excrete a different degree of the nicotine differently in every individual. So we should still be a little bit aware that the person has kidney disease when we're making adjustments to their NRT. But the official recommendation is to not make a change to the dose based on their kidney disease. Let's move to agent 2, varenicline. And I'll give you the same information here. For varenicline, 92% of that medication is excreted by the kidneys, so a lot of it. So if a lot of it's excreted by the kidneys, how would we adjust the dose in someone with renal disease? Maybe I'll get people to put it in the chat. C. Great. I totally agree with everyone that's written C. We do have to decrease the dose. And now a lot of you have probably seen this. Louis Philippe is exactly right that it's for people in severe disease we need to increase the dose. And it sounds like a lot of people have already done this or are familiar with this, but I'll give you the actual uh, numbers. So for patients with mild or moderate kidney disease, so those with a creatinine clearance above 30, essentially varenicline does not need to be adjusted. We can go forth with our standard regimen. In patients with severe kidney disease, so those being a creatinine clearance of less than 30, we want to go to a max of 0.5 milligrams twice daily. So we don't want to go to that 1 milligram twice daily dose in these clients. And for the final population, the dialysis population, we don't know that much how much of the actual, whenever we look at a medication in dialysis, we want to know, does it actually get excreted in the dialysis? And we don't know as much about that question as we do about patients with severe kidney disease, but the official recommendation is still to go with 0.5 milligrams, but at a max of once daily instead of twice daily in patients on dialysis. I put a little caution sign there because, like I said, we don't know as much about the pharmacokinetics here as we do in patients with severe kidney disease. So it's possible for some clients or patients on dialysis that this might even be too much for them. So we just have to be cautious about watching for side effects, though this is the recommended dose. Let's move to our final first-line agent, bupropion. And what I'll tell you there is that when that comes in the body, 87% of it is excreted by the kidneys. So sort of similar sense as before, I won't ask you to answer the question, but how would we actually adjust the dose in people with renal disease for bupropion? Well, if 87%, quite a significant amount, is excreted by the kidneys, we would have to decrease it. And I'll give you the numbers in a second. For people on hemodialysis, studies have actually looked at how much of this medicine, bupropion, is excreted by the actual dialysis machine for hemodialysis. And the actual bupropion is excreted by about the same amount as normal renal function. So we might be inclined to say, okay, well, a lot of the bupropion is actually being excreted by the dialysis, so we can actually give people, once they're on dialysis, the same doses as people with normal renal function. That's not the entire story, because bupropion is actually metabolized into a variety of metabolites, and these metabolites themselves, the excretion of them is impaired for people on dialysis. So in light of that, the question I'll ask you is, because the actual metabolites are still impaired excretion for those on dialysis, how would you adjust the dose for bupropion for those on dialysis? Maybe I'll get people to put it in the chat. Yes, I would agree. I would agree with that answer. Um, so the actual answer here for people on dialysis is that's a great answer, actually, Cheryl, that you would consider another agent or ask a nephrologist to help you out, or do it in liaison with someone's nephrologist. Because the technical answer would be what Carol said. You could go with C for people on dialysis. The official recommended dose is a little bit lower, just because the metabolites are actually have impaired excretion on the dialysis. So if we look at the actual numbers, those with chronic kidney disease stage 1, 2, and 3, these are the typical bupropion doses that I trust many people have seen before. Those with severe kidney disease, so we already answered that question, we have to reduce their dose, so we want to use a maximum of 150 milligrams daily. And for those on hemodialysis, the official recommendation for bupropion is to not go above 150 milligrams every 3 days. Granted, the studies on this are quite limited, so I would say, I think someone above said that Cheryl said that you would consider another agent, such as maybe NRT. That would completely be appropriate, because we don't know as much about how this medicine is used in the dialysis population. But if someone is wanting to try it, or they've tried it and not been successful with other agents, you could try it at this reduced dose, with caution, though, dosing at 150 milligrams every 3 days. And this is a little summary chart that I've made you. I think you can find these in a variety of places online too. But this is essentially some of the dose adjustments for people with mild kidney, moderate kidney disease, severe, or either form of dialysis. Oh, and Dr. Selby is asking a question, so maybe I'll just go back one slide. The concern when they looked at the pharmacokinetics of bupropion for people on dialysis, it totally clears the bupropion, or not totally, but the same amount as normal renal function. The concern is the hydroxybupropion. The excretion of that is impaired because the hydroxybupropion, along with several of the other metabolites, does not get cleared by the dialysis. And that's why the drug companies have essentially recommended the decreased dose. And that's how we get to, sorry to go back, but that's how we get to this 150 milligrams every 3 days. The other thing maybe I'll just take 1 minute to comment on is that I didn't mention this, but this 150 milligrams every 3 days is for people on hemodialysis. We don't know a lot about how this medicine gets excreted by peritoneal dialysis, so I put a little cautionary sign there saying exercise even more caution. The drug companies say 150 milligrams every 3 days, but there's not as much studies to back it up. So that concludes what I wanted to talk to you about. Essentially, tobacco detrimentally affects renal health in people with pre-existing kidney disease or the general population. Smoking cessation or reducing helps. And you can use your pharmacological tobacco cessation strategies in patients on dialysis or renal disease with some dose adjustments, but NRT is the most widely studied, and therefore probably a lot of you are using this first line, which I think is completely appropriate. But if you need to, there are other options available. If clients are particularly interested in those, or you've tried the NRT and the clients now wanted to try something else. So I'd like to thank you for listening, and I guess ask if anyone has any questions, and I think people are already going ahead, which is great. Someone on dialysis, would someone have to take the medication after dialysis to not have that medication excreted in the dialysis process? Yes, so that would be for the that would be, I mean, you could, that would be for the bupropion in particular. You would want to dose it after dialysis. It would get a little bit tricky because typically dialysis is done, let me give you an example, Mondays, Wednesdays, and Fridays, and we're giving this medicine 3 days a week. So the client or patient almost has to keep track of the every 3 days. So if they get it on a Monday, they could take it after dialysis. But then on Thursday, they're not having dialysis, and on Sunday, they're not having dialysis. So they just take it whenever. But on the days that they do have dialysis, they ideally should take it afterwards. Any other questions? I'm also just going to put up my email here briefly. The second one, sorry, the KMH one will probably disappear in a month, so probably the first one is better. But like I think Natalie mentioned at the beginning, I'm going into nephrology, and I'm quite also interested in smoking cessation strategies. So in the next few years, I'm going to be looking at, I think, ways the nephrology community can collaborate with smoking cessation experts. So if anyone has any interest or even questions about my presentation, please feel free to reach out.
Thanks so much, Dr. Pasricha. Oh, it looks like, do we have another comment or question?
Cheryl said something. It's not uncommon for patients looking for smoking cessation pharmacotherapy to also be on atypical antipsychotics. I typically just follow them closely and caution the patient of increased levels with quitting. Does KMH do anything different? So I think you're wondering more about the atypical antipsychotics, not as much related to renal disease. Truthfully, I can tell you what I've learned from the experts here, like Dr. Selby, Dr. Malamed, if they're on the line, but I probably think they're probably better to answer that question, given that they've had more experience with patients on antipsychotics. I haven't seen a lot of it in kidney disease. I'm sorry.
I can put Dr. Selby. Oh, he's there. I can put his email in the chat if that's okay with you, Dr. Selby.
I think he's saying that they also, here at KMH, everyone just educates and monitors, similar to what Cheryl was saying.
Awesome. We do still have some time for questions, so if anyone else does have any questions, feel free to put them in the chat. No? Well, if not, thank you so much, Dr. Pasricha, for such a great and informative webinar. I know I learned a lot myself. So thank you so much again. So just a few little reminders before we head out today. This webinar has been recorded, so I will be distributing a link to all that registered along with the slides this afternoon. So feel free to share this with your colleagues if you would like. I will also be sharing a link to the evaluation and post-learning assessment that must be completed by next Wednesday if you're interested in receiving a letter of completion. As well, just want to take the time to let you all know about our next webinar coming up on Wednesday, February 15th on improving cessation outcomes within Black communities in the Greater Toronto Area. So stay tuned for registration for that opening up soon. And yeah, thank you so much, Dr. Pasricha again, and hope you all have a great rest of your day. Thank you, everyone.